Okay, so the first thing that we talked about in the special collections is we talked about bilirubin. The video did give us a little bit detailed information about bilirubin. What we discovered, just to bring it simple for you all, what we discovered that if the doctor orders a bilirubin, that's because the doctor is looking more into the patient's liver. Maybe the patient has a liver disease that the doctor is trying to figure out. But what you need to do is, okay, what you need, Ebony, okay, what you what you need to remember as a phlebotomist is that when you look at your requisition and the doctor has checked bilirubin, then when you draw that level, you draw it in the tube that it goes in, nothing changes. It's just that when you package it up, it needs to go in a protective bag. Remember that? So basically, when you draw bilirubin, the main thing for you all to remember is that bilirubin, the specimen needs to be protected from light. It needs to have minimum exposure to light, okay? Now, also, I put here in red most vitamins. So most vitamins are protected from light. Vitamin B, vitamin D, all of the vitamins pretty much. But NHA is going to test your knowledge and your skills based off of bilirubin. Once you get out in the real world, you will be orientated to remember that vitamins, once you draw vitamins, they are also need to be protected from light. But just to press forward and to move forward within to be able to pass your exam, bilirubin is going to be everywhere. It is a basic fundamental of phlebotomy, and that test is going to ask you almost about a 3-4 times in a different way. And it cannot be confused for anything else. Only then bilirubin needs to be protected from light. Not bilirubin needs to be on ice. Not bilirubin needs to be locked up in a container. Not bilirubin needs to be anything that it tries to confuse you. What you need to know is that it needs to be minimized exposure to the light, okay? Then right above it, I do have ammonia and lactic acid needs to be on ice. So hopefully you all remember that from learning in your order of draw that ammonia goes in a green heparin tube and it goes on ice. Lactic acid goes in your gray oxalate tube and it goes on ice, okay? It room temperature is not what we're looking for. Frozen is not what we're looking for. We're looking for on ice, like a chill type in an ice water mixture, stuff like that, okay? Now, moving above it, we talked about in special collections, we already pretty much are familiar with the blood cultures because we have been talking about that over and over because it is an order of draw. But the reason why it's a special collection, because remember, we do not use alcohol to clean the site when we're drawing blood for a blood culture. We use the ChloraPrep white, okay, which is chlorhexidine gluconate, okay? Remember, it's always 2 bottles unless you are working with children, infants, so to speak. And they will remind you that only 1 bottle is being used, which is aerobic, but you'll be reminded, okay? But just pressing forward, always remember 2 bottles is needed because that's how the test is going to want to test your knowledge, okay? Remember, if you see anything that states that the doctor is checking for septicemia and bacteremia, that means that the doctor is ordering a blood culture, and that's why it's always 2 bottles. Remember, we need 8 to 10 milliliters of blood in each bottle, okay? Also, remember as a culture, if the doctor orders a culture of any sort, that means it's going to the microbiology department of the lab. That also is going to tell the doctor what is the name of this bacteria living in her blood and what is the antibiotics that can treat this bacteria, okay? Remember, it grows in the lab for 24, no more than 48 hours. So the results do not come back right away, okay? It takes up to 2 days. So remember, special collections, we use a butterfly with the blood cultures, okay? when we collect those. Next, the video talked about right here where I have these bottles. Remember when we looked at the video and I said, oh, those are older bottles, what they used to use. Well, this picture right here is more present day of the glucose drinks. They're small, but they still carry the sugar it needs in order to test the patient appropriately. So you see this, the lemon lime bottle has 50. The orange bottle has 75. The fruit punch bottle has 100. This one has 50 grams. It's like a natural clear type of color. So remember, the reason why this is special is called a glucose tolerance test. If you see GTT anywhere, that is what it means. It means that the doctor is trying to test someone for diabetes, trying to see if their insulin is shooting out of their body like it needs to be. And if it isn't, it's going to let the doctor know in the results. Remember, you draw the blood before, and then you give the patient their sugary drink to drink. After they wait an hour, 2 hours, or 3 hours, and it all depends on what the doctor has on the requisition. After the time allowed it, then you draw their blood again. Both samples still go in your gray oxalate tube, okay? Remember, with this GTT, fasting is not just 6 to 8 hours. Fasting is more on an 8 to 12 hour type of thing, okay? If you have an answer that says 8 to 10, but you don't see 8 to 12, please know that 8 to 10 is still in the range, and that's your answer, okay? Just like the needle angle of insertion is 15 to 30. If you only see 30 and you don't see 15 or 15 to 30, remember, 30 is your best choice, okay? So this is called a glucose tolerance drink. And this is why it is special, because you are drawing blood before the patient drinks the sugary drink and after, okay? Next, it went over what I have written in green. It went over therapeutic drug monitoring. I have it written in green, okay? It talks about these in your book on page 114. Remember, therapeutic drug monitoring is if a doctor prescribes a patient a medication, that he or she can actually monitor the level to be sure if the levels are appropriate for that patient, okay? And we use the example of lithium, which is a psychotropic medication, AKA a psych med, for mental disturbances. So what that means is that the doctor may prescribe me 10 milligrams of lithium. And then after being on it on at least a month, he'll have me go in for different levels. But psychotropic medications and other type of therapeutic drug monitoring, that you don't necessarily have to know the drug to know what therapeutic drug monitoring is. So that's why I'm explaining it as a special collection. When the doctor orders it brand new for a patient, typically the patient is in the hospital. They may have had some kind of aggressive episode, and they typically just went all crazy. And they're inpatient. Let's just say they're at Baptist Medical Behavior Center. My cousin used to work there. So if the doctor orders me lithium for the first time, and you are the phlebotomist that's there, and you get orders in the lab that states, okay, well, Miss Trinity, you have to go draw blood on Miss Chopin at the Behavior Center. She has a trough level at her first dose. So you notice that I didn't say before or after, but because I said trough, hopefully you know that that's before the medication is given, which is what we talked about on Sunday. So in green, trough means before medication. So what that means is you're the phlebotomist. You're not the nurse, the doctor, the CNA. So you like, okay, I got to go draw blood on Miss Chopin. a trough at her first dose? Okay, well, how am I going to know what's her first dose? Remember, we discussed you have to communicate, the lab has to communicate with the nurse or someone on the unit, whether it's you or your supervisor or the team lead. Someone needs to know that Miss Chopin takes her medicine at 8 a.m. So if that is the case, then you have to be at the behavior center before 8 a.m. when that nurse gives the medication. Okay, so it really does take teamwork. Once you get out in the real world, I'm just kind of telling you, in the real world, it takes teamwork. So because it takes someone to communicate with the nurse to see when the medication is due. And then it takes the nurse to know that, okay, I've already told the lab that her medicine is due at 8. So they have to come draw her blood before 8. So it's that nurse's duty to know not to bring that medication to Miss Chopin until the blood work is done. Okay, that's a little bit more detailed explanation. Now, what if Miss Chopin has been in the hospital already for 2 days and she started newly on this lithium medication? You already worked 2 days ago and you were the phlebotomist that had to draw her trough level at first dose. So that means you drew this level before she even took any of the medicine. And now, lo and behold, you was off a day and you came back. And this is her second day being on the medication. And now you get orders to draw a peak level at third dose on Miss Chopin. So it says at third dose, but we should know now that peak means after medication is given. So therefore, if the doctor ordered a peak lithium level on Miss Chopin at third dose, that means that after the nurse gives her her third dose of medicine, you have to be there to draw her blood. So all of this is saying this is your job, but what it's saying is letting the doctor know the levels. What was her level before even taking the medicine, and what is her level after being on 3 doses, so the doctor can see, okay, that's the therapeutic range. They have, just like the sensitivity that comes back on the culture that tells the doctor what antibiotics will work for the patient, they already know the therapeutic ranges. So just throwing numbers out there. Let's just say the therapeutic range for a lithium level is 15. And so because you drew blood on Miss Chopin, a peak level at her third dose, that means after she got her third dose, you drew her blood. And so let's just say when the results come out, the results are, the level says it's 10. So because the normal level is 15, because the doctors have the results like the normal range, each lab, each test have its normal ranges and abnormal ranges. So with that being said, by her levels being 10, it's up to the doctor to say, okay, I'm gonna try her on a few more days of this same dose, or he may say I need to increase it, or if the levels are high, I need to decrease it. So the moral of this particular segment is letting you know that doctors have to therapeutic monitor a lot of these drugs to make sure the level ranges are appropriate in the patients. Where you come in at as a phlebotomist is understanding what trough means and understanding what peak means, because a patient can be on lithium, a patient can be on Prozac is another one. A patient can be on another genre of medications, and you have to do therapeutic drug monitoring. So just to give you an insight, I'm not telling you to study the medications because I'm not giving you any right to study. I'm not telling you to look up a psychiatric book and read in it. I just need you to know, for starters, as fundamentals, know the difference between a trough level and a peak level, okay? Now, if you can key in on my green writing right below, hopefully you took a screenshot. If you have to draw a trough level on your patient, that means before. That can be that the nurse is waiting on you. You come in, the nurse is waiting by my side, waiting for you to draw my blood. Soon as you draw my blood, then he or she is giving me my medicine. So long as you draw it before, it doesn't matter how long, it just needs to be before, okay? But what if you have a peak level and you have to draw it after the medication is given? Well, I'm not telling you to be in the room. So when the patient gives me my pill, when the nurse gives me my pill, I'm not telling you to be waiting right there for me to swallow it so you could draw my blood. You have to have time, because that medication needs time to even work, to even get the appropriate peak level at all. That's the reason why the doctor is doing a peak level. So after it gets into the bloodstream and works its way through. So if you don't mind, please making sure you screenshot, because if you get a peak level, meaning after the medication is given, if that medication was taken orally, like a pill or a tablet or something, you have to wait 1 to 2 hours, no more than 2 hours. If the patient medication was given by IV or injection, meaning a shot, then it takes 30 minutes to get into the system. That's why sometimes if we're hurting, if we're cramping, only because we're ladies, you know what I'm saying this. So if we're cramping or anything like that, and if we have a high tolerance to pain, meaning that when we take that Tylenol or that Motrin, it takes longer to work on us. Sometimes you really don't feel relief until 1 hour or so. But some people who are weak or have a low tolerance to the pain medicine, they may feel it working way before an hour, but it literally doesn't penetrate and get into your system well until an hour. And then if you wait after 2 hours, then you miss the peak level, because it's already working or flushing through the system, as I can better explain it. Okay, so when you are and you will be tested on the big exam for this. So if anything is taken by mouth, it's 1 to 2 hours after. If anything is given by IV or injection, it's 30 minutes after. Okay. Final, the video went over toxicology. And you see, I'm gonna kind of increase this form, because remember, I explained to you all about if you ever see a chain of custody form, and if you're going to be the one that works in forensics, or if you're going to get into criminal justice later, or any type of things, you're going to see chain of custody all the time, because those are the type of fields that, work around chain of custody and, evidence and toxicology and all that. So this is an example of just a general chain of custody. Depending on the county where you're drawing blood at, because it's coming from the courts, their chain of custody forms may look different. Like Jefferson County may look different than Harris County, but it will still say chain of custody. So you see how it has all of these lines here, okay? And all of that at the below, accepted by, time and date. Every time you touch that specimen that has a chain of custody, you need to be sure that you put your name on there, today's date and the time, so they'll know who touched that specimen, okay? Now back to what I have written in purple, toxicology, the study of toxins. Chain of custody, it talks about it in your book on page 148. Chain of custody form is legally ordered through the court system, okay? So when you see that chain of custody, it did not come from Beaumont Bone and Joint. That's the first thing that came to my mind. Or it did not come from Southeast Texas Cardiology or Southeast Texas Internal Medicine. It means that it came from the courts, because it's either one of these 4 tests. Remember, DNA test, paternity test, alcohol test, and drug test. It could be collected via urine or blood. But if any one of these 4 tests were ordered through the court, a chain of custody form will be attached to it. Don't get me wrong, and don't let me confuse you. If Southeast Texas Internal Medicine, your regular doctor, just wanted to see what your alcohol level was, or if you requested for your own purpose a DNA test, for yourself, to where it comes back with the chromosomes and your family tree and your bloodline, or a paternity test. If you just wanted to do a paternity test on whoever, or you wanted, whatever, the more the story is, if these 4 tests is just ordered from your doctor only, it had nothing to do with you being sued or going to court or going through a divorce and in a paternity battle, but it has nothing to do with that. So that means that that will not be accompanied by a chain of custody record. It'll just be your regular requisition. I'm just letting you know that if it was ordered through the courts, it'll be one of these 4, and it will have a chain of custody form attached with the requisition. Okay? Because I don't know if you know, but even in the courts has a physician that is employed through the county, through the courts, because they have so many things that come on, you know, so many cases that can be medical legally that go through the courts. So they do have a medical examiner doctor through the courts. So if the judge say, okay, Ms. Chopin, this is your second DWI, I'm going to request you to have an alcohol test done every week. Now, because it was ordered by the judge, by the courts, even though it's every week, I have to get an alcohol test or drug test or whichever one. And they will have the chain of custody forms lined out to where I have each form, okay? So as a phlebotomist, when you see that form, you always be sure you sign your name, date it, and sign your name and date it and the time that you touched it. Okay, you don't even have to touch the actual tube of blood, but you touch the specimen bag just to put it in another type of casing or to put it in a box. You still touched it, so you have to sign it, today's date and the time. Okay, so toxicology. So when people go through the court system for these things, child support, even though you know child support is in existence, when people go through, that's through the courts. So if he's saying he want a paternity test before he pay anything, then that means that when that person comes to you to get their blood drawn, it's going to be a paternity test, but it is going to be having a chain of custody form with that requisition. Okay. Now, this is all of the special collections that you're going to be tested on. As example, you already had my quiz, okay? Any questions exactly dealing with anything I just talked about with special collections? Okay. All right, I'm gonna stop presenting. If you didn't take a screenshot, go ahead and do that now before I unshare my screen. All right. Oops, I did something else. I hope I didn't mess that up for y'all. I don't know what that box was. All right, ladies. So let me go ahead and do a little bit more before I ask for your participation with flashcards for the order of draw. Give me one moment. I've just been so bloated. This is crazy. All right. Let me go ahead and get the. I'm not going to play the whole video. You know, like I said, it is a 20-minute video, which I hope you all know that because your homework was to watch it, which is why I gave extra time. Give my screen a moment to share. You know it's slow. All right. So this was the video that's in your Remind app and it's still there. So if you want to look at it again, or maybe you felt like all of your attention was not on the video, it is in a Remind app for you to look at again. And remember, we are approaching the end. So if you feel like it is a video that you want to watch again, please do not hesitate to let me know, and I will send the link. Okay. So this is venipuncture complications. Hopefully you know that complications means there's an issue, there's a problem, okay? Something is abnormal. That's what complications mean. And you will see the word complications like it's nothing in the medical field, okay? And I really am excited for you all. I just hope that, you know, someone is eager to start working in the hospital, because that's where you'll start to get a good bit of more experience into healthcare, and it may increase your appetite to maybe go for nursing. You never know. So with that being said, we talked about edema before. Edema is the accumulation of fluid in our intracellular space, AKA, let's just remember it as in the tissues of our body. How did edema happen? It could be anything, okay? Someone can have high blood pressure, eating too much salt, and all of that accumulates in our tissue. Someone just generally, our feet can swell just by standing up for a long time. Our feet can swell because it's so hot, just different things, not just automatically want to diagnose somebody with a type of disease or illness. But what you need to know is that edema means that it is extra fluid in the tissue, and it caused our arm, our hands, our ankles, our feet to be swollen. If you ever come across a patient, ladies, that has an arm, their arm or hand has swelling to it, do not choose that hand, do not choose that arm, okay? As a matter of fact, if you see that the arm has swelling to it, do not choose that hand either. You do not want to contribute to more complications. So just use the other hand. And remember, the other arm or hand. And remember, we're looking at the glass halfway full. So if that other arm or hand is really difficult, you do not feel anything, then, you know, you get someone else to attempt, or you tell your supervisor that patient may just have to come back, okay? If it is a patient in the hospital, remember you have the nurse. Always report any issues to the nurse, okay? Because they're inpatient. That means they're not going to go home. So you have to tell the person that is taking care of them, okay? So we should know what edema is and all of that good stuff. Next, what one of the main reasons, well, the whole video is the main reason I wanted you to watch it, but I wanted to talk about IVs. As phlebotomists, now I do want to tell y'all, you know, I kind of deviate from things, but how you start an IV is actually how you draw blood, okay? But you're not using a blood drawing needle. You're not using a multi-purpose needle. You're using actually a needle for IVs. If any of you have ever had an IV before, basically it's a needle covered by a plastic cannula, as we call it. And when they actually get the needle into your skin, the needle is retracted and the plastic cannula is what's in your skin. And it makes it easy for IV fluids to go in and out of you while you're in the hospital or in the emergency room. I said all that to say that a lot of people think because they took phlebotomy, they can start IVs. But the only way that you can start IVs is if you hold a degree or certification that in the state that you're in allows you to start IVs. And as phlebotomists, you don't hold that certification, doesn't allow for you to start IVs or mess with IVs, okay? The only way that you can actually do that is if you actually worked for a nurse practitioner or a doctor that allowed you to go through IV training, and they allow you to work under their license. Meaning, if you ever heard that before, that means that they hired you and stated that because you've been trained, that you are suitable enough to work for them. But if anything ever happens, their license is on the line, not yours, because they already hired you knowing you don't have a license for that, but they, you know, so to speak, hired you. And most places do that. A lot, I mean, not most places, but a lot of places do that for other entities. So for example, if you want to be a medication aid, you have to be a CNA in order to pass medications. But some facilities will train CNAs to pass medicine for them, and they're working under their license. So if you were to quit that job and you go work at another nursing home because you're a CNA, but you're applying for a medication aid, you don't have the certification that states you're a medication aid. You just have, you have a resume that says that they trained you within their job to pass medications. So with that being said, if you get a patient that has an IV as a phlebotomist, you do not tamper with the IV at all, okay? You do your job and draw the blood. But let's just say you're drawing blood on me, and I have an IV in my left arm. All of you already know my side preference is my left. Whether it's my antecubital fossa area or my hand, you have my left side to work with. But what if you are my phlebotomist and I'm in the hospital and I have an IV in my median cubicle area? So that means you only have permission to draw below the IV site to find a good vein. And so with that being said, it'll be my hand. So according to this slide, I want you to read carefully. It says, do not perform a blood draw above an IV site. The specimen will become diluted with the IV fluid. Use another arm or another site. So let me rephrase that. If you had me as a patient and you walked in and my IV was in my left arm and there's no other choices to draw from, then you have to communicate with the nurse. Okay, I don't see any other IVs in her right side. Veins in her right side, because she said that's not a good side for her. And you can't go to my median cubicle vein because median cubicle is above where the IV site is, which is in my hand. So the moral of the story is that if you get a patient and you get discombobulated because they have the IV, they may even be connected to the IV fluid. You walk out, talk to the nurse can unhook the patient from the IV fluids, and then you go ahead and draw your blood in a vein that's below the site. If you have difficulty and there is no site of choice that you feel comfortable with, then you need to report to the nurse and let him or her know, okay? So I need you to know, you draw blood on a patient with an IV below the site, not above, okay? Let me know if you have any questions. All right, next on the list, I mentioned mastectomies a little bit in class on Sunday. So what this means is that this patient has had a right breast removal, okay? Remember, phlebotomy, also mastectomy, remember phlebotomy is to cut a vein by way of needle. So ectomy is to cut. So basically, mass means breast. So a mastectomy means that someone cut into that patient's breast, okay? So mastectomy is breast removal. What you need to know as a phlebotomist, when you ask your patient what arm preference do they prefer, they should be able to tell you something like this. Oh, you can only draw in my right arm or hand because I've had a mastectomy in my left, okay? So in other words, you can basically tamper with the medical term is lymphostasis, but just remember lymph, they're lymph nodes. You can actually tamper with their lymph nodes if you draw on the side that has had a breast removal. So that's why you need to draw on the opposite side, okay? So the sites of breast removal, use other arm, okay? Double mastectomy, on the other hand, you can draw from the hand, okay, or do capillary punctures. So let's just say your patient is in the hospital currently, right now, because she had a double mastectomy, so things are fresh. So that means that in the hospital, though, and in the nursing home and inpatient, it is the nurse's duty and the facility's duty to put up signs. So just like those signs that I showed you on Sunday about droplet precaution, airborne precaution, and contact precaution, well, in the inpatient facility, if a patient is on dialysis or had a mastectomy, they will also have signs over the bed and on the door that says no BP or blood draws in left arm, right arm, okay? And it's because of a mastectomy, or maybe they have dialysis and they have that dialysis shunt on that side, okay? But the more of the story is that you are welcome to draw in the hands of a patient that has had a mastectomy. So in other words, if the patient has had a mastectomy on the left side only, and you know you're good at drawing from the median cubical vein. So if he or she, you can feel a median cubical vein on that opposite arm, then draw blood there, okay? But if you don't feel median cubical cephalic, vice versa, then you only have the hands anyway. But if that patient has had a double mastectomy, you only have the hands. If you ever feel in doubt, please ask your supervisor or ask the nurse that's in the hospital. Okay, so as the phlebotomist, I need you to know what a mastectomy is, and I need you to know on what side is appropriate to draw if the patient has had a mastectomy. Okay. I've gotten some students to ask me, well, what if they had the mastectomy 5 years and 10 years ago? The rule of thumb is still follow these rules unless the patient has orders from the doctor that says it is okay because she had a right mastectomy 10 years ago. It is okay now to draw from the right side. You have to have some kind of documentation, or somebody has to upload it in the chart. So when you bring that patient up in the computer, it's already there. Okay. If you don't see it or whatever, then go with the being safe. Okay. Any questions regarding the mastectomy? All right. So potential problems associated with tourniquet application. Remember, our tourniquet is supposed to be tied in place for 1 minute, which is basically 60 seconds. Okay. Remember, we learned in medical terminology that if the tourniquet is in place for too long, you can jeopardize that blood sample to be hemoconcentration. Okay. Tourniquet on too long. And on this slide, it said it can cause a hematoma and hemoconcentration, but the way NHA tests your knowledge, hemoconcentration is the only example they use for extended tourniquet use, or that they're going to test you. Okay. Also, if the tourniquet is too tight, it can also stop the flow of blood. So if your patient tell you that, oh, this is too tight, then we want to loosen it up a little bit. Okay. And by the way, I want you all to continue to practice tying these tourniquets for me, please. Please, please, please. Continue to practice with these tourniquets. Okay. So that's potential problems with the tourniquet use. Now, the infamous medical terminology word syncope. Remember, syncope means fainting. Maybe they was near fainting and they felt dizzy and you all caught them and talked to them and they never fainted. Or maybe they did faint, okay? So signs and symptoms, what to do. If a patient is over sweating, and I remember in class, I don't know who it was practicing, someone start to sweat. So you want to pay attention to your patient for that, because they could be really anxious and really scared and heartbeat beating fast to get their blood drawn, and they can actually faint from it, okay? That's why it's it's a good technique to talk to your patient while you're doing your blood draw, okay? If the patient starts to have pale skin, all of a sudden they're just turning, they kind of turning pale, they turning white, you want to pay attention to that. If they start to breathe, shallow means slow. If they start to breathe shallow, or if they start fast breathing, we want to pay attention to that. Drooping of the eyes, Really, the only way that you can really pay attention to the drooping of the eyes, they're probably already near faint. They probably about to faint, which is why their eyes are droopy. Okay. Rapid or weak pulse, which is the heartbeat that we talked about when we were doing CPR. And finally, they may just go unconscious. Okay. So when they faint, they're unconscious. Remember, we have to yell their name out. Hey, Mister, are you okay? Are you okay? And then if they not responding to you, then you have to look, listen, and feel, and that's where that pulse come in at. Okay, so we thought the patient fainted, but you want to be sure the patient fainted. And so if he has a pulse and breathing, then yes, he's fainted. He just have not come to yet. Remember what I showed you on Sunday. Most labs, all labs have ammonia where you wipe under, not wipe, but you yeah, kind of, not wipe the nose with it, but you just bring it by the nose to let it inhale, and the patient will come to with the ammonia. Okay. So what you want to do is quickly remove the needle and tourniquet and call for help. But remember, tourniquet then needle. Okay, not needle first, because you don't want any extra blood to come out. Okay, make sure you apply pressure to the site. You want to lower the patient's head between their legs. So in real life, you're going to have a phlebotomy chair. Just having the patient lay his head down on the chair, like if you were by being a student, and you just put your head down, that's good enough. Okay, but if your patient totally goes unconscious and dead weight, you need to get help to lower him or her to the ground. Okay, because the chair is not going to help, because if they go to, they end up being dead weight and off balance. Okay. Also, you may have the option to apply cold compresses to the back of the neck or the face. They could have overheated, and that's why your labs have cool packs to cool someone down, and it have warm packs to warm people's fingers and heels when we do capillary puncture. Okay. If this was to happen to you, ladies, just please be sure that you pop the tourniquet and remove the needle, apply the safety, apply the pressure. Make sure you call for help, because you're going to need help once your patient goes unconscious. Okay. Now, if your patient has a seizure, or maybe your patient went into shock, maybe he's a diabetic or she's a diabetic, and they're unconscious because they're in a diabetic coma. Maybe their blood sugar is extremely high or their blood sugar is extremely low. What if they start to say, oh, I feel nausea, I feel sick to my stomach. Okay. Or what if they actually vomit? Okay, we want to discontinue the procedure, which means pop the tourniquet, remove the needle, apply the safety, apply pressure, and we still call for help. Okay. If your patient has a seizure, you always want to put your patient where he or she is out of harm. Move the equipment. Make sure you stand clear. You let them shake and do these involuntary movements until they're done. Okay? Don't ever try to stop your patient. If you're moving towards your patient, it's because I see you trying to move the equipment out the way so the patient will not be in any type of harm. Okay. With this slide, hopefully you looked at this slide, because another medical terminology that I'm gonna probably start putting within my medical terminology segment, this is pronounced phlebosclerosis, which a lot of people remember the word sclerosis because phlebo means vein. I hope you are comfortable with knowing what the prefix phlebo means. With the root word phlebo, that's another name for a vein, like phlebotomy. Okay, so phlebosclerosis, if we just attach on or cling on to the word sclerosis, I want you to remember that. This mainly happens in older patients, as they call it, geriatric patients. The reason why someone may have sclerosis in the vein is because they constantly get their blood draw from that median cubical vein, or they're constantly hospitalized and they're always giving them their IV in that same vein. Okay, so that's why it says frequent venipunctures will not give adequate amount of blood if that patient vein was phlebosclerosis or sclerosis. Let me tell you, if you feel for my median cubicle vein and it's not bouncy and spongy and healthy as it needs to be, but guess what? It feels hard. It feels like a cord. You know, just imagine a plug cord or any cord, and it's hard. And you're like, well, wait a minute. That seems like that's her median cubicle. Don't second guess yourself because you know what a median cubicle is. So it's probably 8 times out of 10, her veins is hard. So therefore, you can feel it and it's hard. And that means her median cubicle is no good for you today. Okay. You cannot draw from that vein because you're going to cause your patient more discomfort and you're not going to really get any blood from it. Okay. So I need you to know that it's hard and cord-like. What should you do? Choose another site. So when you feel and it's hard, do not go for it. Remember, we want to work smarter, not harder. I don't want you to stick that patient, cause him or her pain, don't get blood, and still got to stick them again for the second time. And it is a such thing as this. I go through this as many more times than you ever know with patients having hard veins. And they'll tell me, yeah, I go here. I'm always in the hospital. I have this. I have this. I have sickle cell. My last patient, I have sickle cell and I'm constantly in the hospital and I have to go for IV infusions and they always stick me in this vein. Okay. So sclerosis means hard. Phlebo means vein. So when you put them together, a hard vein, your vein is hard. Okay. So with this segment, we talked about this, you know, in the beginning of learning how to stick our patient with the needle, okay? Remember, we want to be sure that the correct one, which is letter A in this diagram, we want to remember that we're sticking over the vein, straight through the middle on top of the vein, okay? We don't want to bevel be on the vein wall. So just think about it. For those of us that did sticks on Saturday, and then, you know, you probably heard me say, or even you even thought, man, I thought I was in the vein, because you see the big vein, but then you didn't get any blood. So it could be a series of options. Like B, the bevel is on the vein upper wall. And that means the needle is touching the upper wall, but there's no blood to come in the needle because we're not directly in the vein. We're on the wall of the vein. Okay. Letter C, the bevel on vein lower wall, same difference, it's just on the lower wall. So if you got that needle, on that wall, then it's hard for the blood to get in the needle because you're on the wall of the vein. Okay.
Yes.
Oh, you talking to me, Ebony? Us? And then D, you have the needle inserted too far. So like, man, the vein was right there in my face, you know, and you like, I know I'm gonna get it. And then because your angle being too much, we went through or too far into the vein. That's why if you look at D, actually the angle is somewhat really good. But when you look at D, this is an option where you pull back on the needle a little bit, because if she pulls back on that needle, she will then be in the vein. Okay. Option E, partial insertion, meaning that the bevel is inside, partially in, partially out the vein. So we're not getting any blood from that. Letter F, a collapsed vein, meaning that you felt the vein, but as soon as you inserted that needle and attached that tube, the vein collapsed. It just closed. And because of it, we can't get any blood. Okay. Number 2 talks about on the other side, tourniquet is too tight. We already just talked about that. If the tourniquet is too tight, you will not get any blood. Okay. Number 3, insufficient vacuum in the tube, meaning that maybe somebody punctured the tube already. So when you go to use it, it's not giving you any blood because the vacuum seal has been broken. Also, if that tube is expired and you use that tube, not only is the lab going to reject it because the tube is expired, but depending on how long that tube has been expired, that vacuum may not work well on that tube, and which is why it's not giving you any blood. Okay. Number 4, we talked about collapsed veins. Very last thing that it talks about on this slide that we already should know is that we get 2 sticks only. Please remember that. 2 sticks only. Okay. Now, right here is an example of hemolyzed blood. For example, that's what they're showing us. But it is hard to really see if the blood is hemolyzed with our bare eyes. The only person that can really even tell us is the medical scientist or the medical chemist that is actually resulting the blood. So let's remember, what is a hemolyzed sample? It means the red blood cells have been damaged or destroyed in that tube. What is the causes? Well, typically, if the needle is too small and we stick the vein with we stick a little needle with a big vein, it can hemolyze the blood. It's kind of, not as common. But number 2, where it says inverting the tube too forcefully, that is what you need to remember for sure. That's what the test tests your knowledge on. Vigorously inverting the tube or forcefully inverting the tube. Okay. Also, it says if we do not allow the alcohol to dry, we can cause that blood to be hemolyzed. Remember, we have to allow the alcohol to dry because not only that, our patient will feel a little sting as the needle is going in. Okay. Now, remember that question that we asked about, Ms. Chopin, do you know if you're on any blood thinners? And either she tells you yes or no, okay? But remember, we also are aware that if we do take out a blue tube because the doctor ordered a PT with INR or PTT, that also lets us know that a patient is on a blood thinner of some sort, okay? So right here, prolonged bleeding time from the site. So if the patient is on a blood thinner, we know for starters, we hold pressure 3 to 5 minutes. But if we lifted that gauze up and we know that it's been 5 minutes and that patient is still bleeding, that's what makes it a prolonged time. And the patient told us he was on blood thinners, okay? So aspirin, actually, that is over the counter, 81 milligrams, is a blood thinner. It really is. And some doctors do order it for our patients, for the patients to take every day. Some of our grandparents or older family members, they may automatically take it on their own because they was raised up to know that it was a blood thinner, and what they was raised up to know that it can prevent a heart attack. Okay. But it is a blood thinner. And, like I said, as a phlebotomist, the whole blood thinner thing is to just give you insight, because if the patient bleeds longer, it just makes you say, okay, I expected this because she told me she was on blood thinner. So you just have to hold pressure some more. Every 3 to 5 minutes you check. The moral of that is that we do not let our patient leave from our cubicle or leave from his or her hospital bedside while still bleeding. We don't want to still be actively bleeding and you put that gauze down and put your Band-Aid on there, okay? And again, as a new phlebotomist, be sure that when we lift up the gauze to check for hemostasis, some of you have been just removing the gauze and putting a Band-Aid. We want to leave the gauze there, okay? Because again, We know that's probably how you like it at home and you just want to keep it like that. But you want to minimize any problems with your patient. Okay. You don't want your patient to have to call to the lab and say, I got it all under control. But when I left and got in the car, I was bleeding everywhere. And all she gave me was a Band-Aid. She didn't even give me no good gauze. So just try to leave the gauze. It does not have to be big and bulky. You just basically take one layer of the gauze, fold it up in 4s or 2s, and wrap it up with the Coban or put a Band-Aid on it. Okay. So what do we do if the patient does have prolonged bleeding? We want a firm, steady pressure until bleeding stops. And sometimes if the bleeding still persists, you grab that ice pack out of your lab. Okay. That's why nowadays when people have a nosebleed, the most recent research is to apply ice pack to the nose, not to put your head back, because the research has shown now that if you put your head back, you are liable to choke on your own blood. Because remember, our ears, nose, and throat is attached to one another. So if you swallow your blood or think that, that's helping, you can actually choke on it. And the reason why you're choking is because your head is all the way back and you have a hard time swallowing like that. Okay. So that's why nowadays people are to put their head down, but apply ice pack on it while they're doing that. It helps stop the bleeding. Okay. Next, I'm not going to go over this too long because I think we already are comfortable and we know about the bacillic. We know not to really touch it until we get confident, maybe in 6 months or so. And I'm not saying you could be more than, less than 6 months, but we know per our textbook sense that it is the third vein of choice. But in the real world, we're just going to skip over it. But if you ever puncture an artery, remember I told you that blood is bright red, like bright, nice, pretty blood. What should you do? Stop that procedure right now. Pop the tourniquet, remove the needle, apply the safety, and apply pressure really firmly, and just stay like that, okay? We want to be sure that that bleeding stops. So what do? Stop the procedure, remove the needle, apply firm pressure. If you ever puncture an artery or, get artery blood, okay? So these are many type of incidents or, instances where your blood sample you may not can get any blood. As proven fact, some of us had experience this weekend. You learn from learning. So what we did this weekend, you'll just get better. As I told some of you, that if you feel that you're in the vein and you feel like, wait a minute, her vein is big, I should be in there. And you go up a little bit and you come back a little bit, blood still doesn't flow, you adjust your angle just a little bit. You may want to change your tube because that tube could have been tampered with, and that because of it, the vacuum seal is not working. We already talked about repositioning the needle. We can go in a little bit and back up a little bit. We're never to fish. But we can, when we back up, we may want to bring our angle up, or we may want to bring our angle a little down and then go back in. If you're doing it gently, the patient will not feel all of that. If he or she is looking at you, they're probably going to be anxious because they're seeing you do it, okay? And then another thing, you may want to adjust your tourniquet because remember, it could be too tight. And I'm saying all of this, and it doesn't have to be in one sitting. You can be on your second attempt, and then you be sure that, you do these things, okay? Most of your tubes, not most, but all your tubes need to be filled, okay? Remember, it is a vacuum, so it'll stop on its own, but they do need to be full when you bring them to the lab. the lab will reject your sample if it's not full, if it's hemolyzed, if the tube is expired. It'll be several instances where the tube will be rejected. If the tube is rejected, the patient just have to be redrawn again. We talked about hot and cold packs already, okay? We talked about all of this stuff, so just be mindful and just be sure that you remember in what ways will you use a cold pack, and in what ways will you use a hot pack, okay? Remember, as a phlebotomist, the patient can also be having complications because they have fear. If you ever see that word phobia, it means that they're, they have a fear, of something. A needle phobia, maybe they're scared of needles, okay? It could be anything. Some people are just scared to go to the hospital, period, okay? Maybe they had a bad experience. Maybe they had a hematoma before and it really hurted. And so because of it, they're scared to get their blood drawn, okay? Ways to avoid or ways to help your patient to be in a calm state is to explain what you're going to do to your patient, okay? As discussed in professionalism, you want to be confident. If you're confident enough, you can be scared out your mind. But if you are resembling a phlebotomist of confidence, that will relax the patient, okay? And make sure you follow all your guidelines and procedure steps, which is what I ask of you when you go home and when you start drawing blood on your loved ones. Follow the guidelines. Make sure you have your clean area. Make sure you take your time. It's not a race, okay? Make sure you use that alcohol. If you touch it, make sure you wipe with alcohol again, okay? Just be gentle, but don't be so slow that maybe your patient is being scared, okay? But the more you practice, the better you're gonna get. I just can't wait to, hear you guys and know that you practice some more, okay? Now, this is one of the questions. Veins that feel hard and cord-like when palpated may be collapse, fistulars, or sclerosis. Tell me in the chat what you think the answer is. Okay, Trinity, I got Trinity's answer. I got Alicia's answer, Melissa's answer. Okay, that's it. Veins that feel hard and cord-like are called sclerosis. And guess what, y'all? I think this video has been out, but I think that's an exact question on the test. Number 2, when the arm of the patient is swollen with excess fluids, the condition is called which one? 1, 2, or 3? That's right. Good job. Easy. And I think this is also a similar question, if not the same exact question, okay? So this is the video that, I wanted you to watch on your own. I may have did more explanation than I wanted to, but it is what it is, okay? I want to be sure that you all get an understanding of everything, because honestly, that video right there, the information that we've been doing, all of your basic phlebotomy fundamentals, that wraps it up. Okay, so now it's just time to put it all together. Okay, Thursday we will play Kahoot. Thursday we will do NHA practice questions, probably for an hour, where I will ask for your participation. We will learn how NHA is asking the questions so you can get familiar. We would do the questions, but we will go over why the wrong answers are wrong and why the right answers are right. So therefore, it could just help you in your learning technique when you're doing your questions, okay? And remember also on Thursday, I have an agreement for a guest speaker to speak to you all, okay? But we're not done. Hold on for me. I want to do a little participation, which will involve you typing in the chat. I cooked spaghetti today, last night. That's a shame. That's why I keep getting fat. All right. So for those of you that have heard of Quizlet before, remember on our first day, I did send you in your welcome email a Word PDF document that talks about the study materials that we'll be using throughout the class, and you can continue also using. Quizlet is a good platform. Quizlet is a good platform for you to look up phlebotomy stuff, for you to look up NHA stuff, which is the company that you will be taking your national exam from. So just keep that in mind because it's a good study tool. You know, you may think it's a good study tool, but it is open to anyone. Now, the more you practice, it may tell you to start an account. You shouldn't have to pay for anything unless you want some of the information that could be like flagged, like as if you know, you have to buy a subscription anyway. So I just want you to keep that in mind. But most of it, you should be able to freely do things. Okay. So without further ado, I want your participation. Is my internet acting cuckoo? Okay. So without further ado, I want your class participation. I want you to put in the chat to me what comes to mind when you think of a tiger top tube, which is another word for it, which is marble top. What comes to mind? Great. I have SST, serum, okay. Serum SST because it does have a gel, okay. What else? What order of draw it comes in? How many times to invert it? What's the most common test? Five inversion, CMP and BMP. Good job. What order of draw does it come in? Third in the order of draw. Good job. So when I flip the flashcard over, the additive is a serum separator gel. Okay, so we know it is a serum tube. It is SST because it has the gel in it. Don't forget, it's a clot activated tube. So when the blood goes in that tube, it does have to sit to clot before you put it in the centrifuge machine. Okay, the most common tests: CMP, BMP, liver, etc. And the etc. we can add the lipid because that's what we've been learning. Okay. What comes to mind with that light blue top tube? Citrate. Okay. What else we got? Have. Draw order two. So second in the order draw. PTINR, PTT test. Yes. Not 5 inversions. How many inversions? 3 to 4. 3 to 4, 3 to 5 times inversions. Yep, I see you, Alicia and Miss Melissa. Sodium citrate is the additive. Good job. Second in the order of draw, citrate is the additive. We inverted 3 to 4, 3 to 5 times. Most common test, PT with INR, PTT. Also, the patient is most likely on a blood thinner medication. Okay. When we flip it over, additive is the sodium citrate. We remember it by citrate. Test, PT, PTT, PTINR. Okay. Hopefully by now that this Bluetooth is kind of like, hitting us. Like, oh, okay, I'm getting to know this one because all them PTs and stuff. Okay. Blood thinner. Okay. What comes to mind with that gray top tube? Oxalate. Yep. Glucose, oxalate, and GTT. Yep, because that's a part of the glucose testing. Good job. 8 inversions. Yes. What number of the auto drawer comes in? Last. There you go, Trinity. Last and 6, Melissa. Good job, y'all. Okay. When I flip it over, potassium, oxalate, sodium fluoride, we know, right? But oxalate is what we remember it by. The most common test that NHA is going to test you on is glucose. Blood alcohol does go in the gray top tube, but it's not a common test. It's it's real, but unless you just want to remember it, you can, but it's not the basic fundamental that they're going to put on the exam, okay? So we just remember it by glucose. And of course, if you see lactic acid, it goes in a gray top tube on ice that we circled on our blood tube paper. It's last in the order of draw. Good job. Black is not in the order. That is not in the order. Royal blue is not in the order. Remember, ladies, do not let me confuse you all. I think I mentioned this a few times. There are other colors of tubes out there, but it is not the order of draw, meaning that it's not in the basic fundamentals of the order of draw. If you do work in a lab that you see yourself and you were taught to draw black tube, to draw royal blue tube, to draw tan tube, they will teach you that because those are special laboratories. Okay, so you'll get taught that, no worries. Now, what comes to mind with the green top tube, ladies? Stat, I like that. That's right. Heparin is the additive. Thank you. The additive is lithium, and one of the tests is stat. Okay. All of the tests will be stat pretty much in that green top tube. Lithium heparin. We inverted 8 times. Good job. What order of draw does it come in? 4. Good job, y'all. Thank you. Good job. Okay. So when we flip it over, lithium heparin is the additive. The most common test is STAT, CMP, BMP, liver, etc. So now you see the same test that can go in your serum SST tubes will go in your heparin tubes, but only if the doctor orders it STAT. So when you're looking at your requisition, you see S for serum SST everywhere. You don't see heparin, right? The only way you know it's heparin is because the doctor said stat. Only for those tests, not for the tests that go in the blue tube, not for the tests that go in the oxalate tube, not for the tests that go in the EDTA tube. Only serum can go in the green tube if the doctor ordered it stat. So these are the very similar tests, okay? So good job. 4th in the order of draw, stat. Heparin is the additive, inversions 8 times. Red, we kind of did that already. Lavender, What comes to mind with lavender? Remember, lavender and purple is the same. Ooh, EDTA. Additive is EDTA and the test is CBC. EDTA, EDTA. Good job. How many times to invert it? What order of draw does it come in? 8 inversions. Good job. I think now you all are realizing the last 3 we invert 8 times, which is the green, which is the lavender and the gray. All of those are 8 times. Only the serum is 5 times. Only the citrate is 3 to 5 times. Okay. Fit in the order of draw. Thank you. And Melissa, I saw that. Okay. Good job, y'all. I like this. So when you flip it over, the additive is EDTA. The most common test is CBC. But I did have you circle SED rate and hemoglobin A1C as well. But CBC is the top one they're going to test you on. So please remember that. And hopefully when I showed you those the results, hopefully that also made a little sense. Okay. Helped you, make it. I think that was it. Yep. Okay, good job. I hope that you found that helpful, but please remember you can always get on Quizlet. You can always get on Quizlet.